Good evening and welcome to First Aid Chats by Dr. G. I'm Dr. Adana Grandison, a physician in Barbados and your hostess for this evening. First Aid Chats by Dr. G is a live podcast that provides listeners with a unique opportunity to not only hear complicated medical conditions explained, but also clarify any misunderstandings you may have about that condition. After all, a medically aware and educated patient is an empowered patient. And this evening, our episode is entitled Let's Talk Bipolar. And our guest is Dr. Maisha Emmanuel. Dr. Emmanuel graduated in 1997 with an MBBS from the University of the West Indies and then went on to complete her postgraduate training in psychiatry in 2002. Subsequently, she undertook a Master's of Science in Forensic Mental Health Care with merit from the University of Birmingham, UK in 2006. Currently, she is a lecturer in psychiatry with the University and the West Indies and is a consultant psychiatrist at the Queen Elizabeth Hospital since 2005. Dr. Maisha Emmanuel has actually been on our show before as we had a discussion about depression and anxiety. And this evening, we welcome Dr. Maisha Emmanuel again as we have our discussion, Let's Talk Bipolar, on World Bipolar Day. Good evening and welcome, Dr. Emmanuel. Dr. Emmanuel is just trying to call in at this point in time. I'm seeing her in the room. Yeah, she's just probably having a bit of a technical difficulty, so we'll just wait as Dr. Emmanuel comes on to the call. Dr. Emmanuel? As Dr. Emmanuel joins us, uh, I wanted to highlight to you that it is World Bipolar Day. This is a day that, quite historically, a topic that is quite taboo in some populations, but certainly should be something that we all should be very much aware of. Generally celebrated on the 30th of March for this year. And this year, what we want to emphasize is for persons to get involved with World Bipolar Day. We're just waiting for Dr. Emmanuel to join us. Dr. Emmanuel, she has been having a bit of difficulties with her headset, but she should be on with us shortly. Okay, because technology can give us problems, I'm actually going to try for a different way to actually get Dr. Emmanuel into the call room so that we can proceed with our conversation. Okay. As we try to get Dr. Emmanuel on the call via another mechanism. We're going to continue to try to reach Dr. Emmanuel. Hi, Dr. Emmanuel. Hi.
Can you hear me?
Yes, we can hear you here.
Oh, wonderful. Okay.
Okay,
So
great. We're going to try we tried a different way to patch you into the room.
Okay.
Simply because sometimes we can have technological glitches, but that's okay. That's not going to stop us from talking about bipolar disorder this evening at all.
This show.
Absolutely.
Indeed not.
Absolutely.
So what do I need to do? Oh, can you hear me loud and clear here?
Can everyone hear Dr. Emmanuel nice and loudly? She's actually able now to get on.
Oh, wonderful. Am I on?
We still can't hear you via the other. Speak again, Dr. Emmanuel.
Can you hear me now?
No, we can't hear you via that means. So we'll just continue our conversation this way. That's okay. That's not a problem. So, Dr. Emmanuel, just tell us a bit about really what is bipolar disorder. Let's start there.
Well, we said bipolar disorder, but really it's a group of conditions because every person who's going to have that diagnosis will pretty much experience it in any number of ways.
Absolutely.
So, as it says, it's bipolar. So you're looking at two poles, so to speak. You have the depressed side and then you have the manic side. So typically, somebody who is presenting with what we call bipolar 1 will experience episodes of depression and at other times have episodes of mania. So I'm going to break that down a little bit because sometimes it can get quite confusing about what is happening exactly with the person. So the episodes of depression, it goes beyond just saying, well, I feel down today, or it's Monday and I really don't like Mondays, or I don't like Tuesdays. When we talk about a clinical depression, we're saying that this person is experiencing low mood for most of the day, for most of the days of the week. Okay?
Right.
In addition to that, there are any number of other symptoms the person may be experiencing. And to make the diagnosis, these things must be happening for at least 2 weeks. Again, it's not just, well, I'm upset today and therefore I'm depressed. That's not how we make that diagnosis. So feeling low in mood is one symptom. Sometimes people describe losing interest in things that they once felt great doing. So you find people say, I don't want to go running anymore. I used to like gardening. I'm not doing that anymore. I don't want to do my usual hobbies. All those things. People lose interest in that type of activity that they would normally like. Other things that happen when you become clinically depressed include changes in your sleep. So most times people report not being able to sleep, whereas sometimes you can have the opposite thing happening where you find that you are sleeping too much. There are also changes in your appetite. Again, most times people describe not having appetite and losing weight, but then again, some people come from eat and they put on weight. You have people who lose concentration, they report feeling tired all the time. People who are close to them recognize that this is a change, person is slowed down or they're very agitated and irritable. And then the thing that really worries us as psychiatrists and mental health professionals, when people are having thoughts of hurting themselves. Sometimes it's something as, I wish I could just lie down and not wake up. All on the other end of the spectrum where people are making active plans to commit suicide. So that's the one side, that's the depression. Right. And to make criteria for depression, you need, as I said, 2 weeks minimum and at least 5 of those symptoms. So we're not saying that everybody is going to present the same way and every single episode. And that's why everybody's experience will be very different. So that's the depression side. Remember, I said it's 2. So there's the manic side. So somebody with bipolar 1 would have symptoms of mania, where, for example, they don't need to sleep. So whereas the depressed person would say, I cannot sleep, I'm tired, but I can't sleep. The person with that symptoms would say, well, I don't need to sleep. 2 hours is enough. I'm full of energy. I'm bouncing on balls. I'm doing these fabulous things that help the answer to world peace. I'm going to meet Barack Obama, and we are going to have lunch together. Get all these grandiose things, all these plans, thoughts racing through your mind, very distracting. As I said, lots of plans, bouncing from one thing to the next, but not quite finishing something. Quite agitated. And sometimes these behaviors, this energy and all this great mood can lead to problems, right? So people get engaged in all sorts of things, like spending a lot of money, running up credit card debt, having sexual encounters with strangers. I mean, so you can imagine it is problematic. And I think part of the problem is that when somebody starts to feel hyper, so to speak, in the beginning it's great because you feel happy and you're the life of the party and you're telling jokes and you're well engaged and all is well. The problem with that though is that it doesn't stay there, right? So if you leave a manic episode untreated or you don't recognize it as a manic episode, the person progresses to more and more and more problematic behavior. Right. But it's one thing if you're telling jokes and people find you funny and entertaining. It's another thing if you are up all night calling people, making a nuisance of yourself, or spending a lot of money shopping on the internet, and the next thing you have a $20,000 credit card bill, and so
that realistically, in that way. That realistically, you don't have any way of resolving. So it's making decisions that are not in your best interest.
Exactly. So in the moment when you are manic, you have lost touch with what is true and what is real. We have had situations where people will get on a bus and pay the conductor $200 for a trip. Now, if you have an unscrupulous person, they'll be very glad to take your $200. But in a situation where the person recognizes, but this is very unusual. Why is this person giving me so much money to take a trip that normally would take $3 or whatever it is? So we've had people get into problems, especially when it comes to spending, gambling, one night stands. So it can become a significant problem, as you can well imagine. So it is not okay to just laugh and say, oh, ha, 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 this person is just being funny and, entertaining us, because it does not remain there. Things do escalate.
Right. And that is quite important, because a lot of persons just say, okay, well, I might just be happy today and sad tomorrow. So I'm very glad that you actually made that the real distinguishing features of bipolar 1, especially with the depressive episodes and then the manic episodes that you can have as well. Can you also tell us a bit about cyclothymia? Because there are some terms that are tossed around in there that sometimes persons may hear associated with bipolar disorder.
Right. So I said bipolar 1 just now, and so I'm going to talk a little bit about bipolar 2 and cyclothymia, just so that the listeners can compare the three different conditions and understand why they are different.
Right.
Okay. So I just described intense depressed episodes and these manic episodes. And these episodes, much like how depression, you need at least 2 weeks of symptoms and a certain number of symptoms. With manic episodes, you need to have at least 1 week of a certain number. But with bipolar 2, you get the same type of depressed episodes, but instead of the intensity and the number of manic symptoms, you now have less intense symptoms and a fewer number of symptoms. So it's like the same thing with depression, but now with bipolar 2, we describe hypomanic. So you're not as high as if you're having a manic episode with bipolar 1. Okay? So just to be clear, bipolar 1 is depression and mania, whereas bipolar 2 is depression and hypomania. So when you are on the side, when your mood starts to lift and you start getting elevated and you're developing some inflated self-esteem and you're starting to talk, you are higher than usual, but not as hyper or as high as if you're having a full-blown manic episode. Right? Which is distinct now from what you were talking about, cyclothymia, where people have some symptoms of depression but never meeting criteria for clinical depression. And you have some symptoms of hypomania but never quite meeting the criteria for hypomania. And these symptoms have been going on, waxing and waning for a long period of time, like over a 2-year period. So if you think of it on a graph, if you were to think in your mind how with something that's cycling, the bipolar 1 will have high highs and low lows. The bipolar 2 will have not so high highs, but the same lows. And the cyclothymia, again, not as high and as low, but spread out over a much longer period of time. Okay? So I hope that kind of clarifies in the listeners what it looks like. So people who are cyclothymic will give you a much longer history of their moods going up and down. But they will say to you, but I can still go to work or school, but there are times in there, a month or two in there where it may get a little bit more difficult. Whereas somebody who's having a bipolar 1 episode of mania, I mean, it's so obvious. As I said, it's within a week. The person has this dramatic change where you're thinking, what is going on? She's talking, and she's jumping from one thing to the next, and lots of energy and lots of plans and lots of grandiose ideas. And when things escalate, people can become quite delusional, meaning the things that they're talking about just don't make sense. And as I said, it's usually of the grandiose nature. So these fantastic things about traveling the world, and this particular person, high-profile person, is their friend, and we're going out to have dinner, and you're thinking, but this cannot be true. So the person at that point who was having a severe manic episode would have lost touch with what is real and what is true and what is happening. And that's where you can have these problems, because obviously somebody's making these irrational kind of impulsive decisions based on what they believe is true. You can understand why these problems can come up for that person. Think of somebody at work who is behaving in this way.
Right.
Can't sit still, telling off co-workers, insulting the customers, screaming at the boss. It's just not going to work, right? Whether it's a workplace or school or even in town.
Right.
We all know the rules about social behavior and that kind of thing. And unfortunately, that can get lost when somebody is having a particularly manic episode.
Dr. Emmanuel, what causes bipolar disorder to develop?
Well, it is the one condition in general, in psychiatry, we always talk about genetics and environment, and especially things like stress. But when it comes to genetics, bipolar is very, very heritable, meaning that it is the condition in psychiatry that has a very strong genetic component.
Mm-hmm.
Okay, so for example, if you have one parent with bipolar, the risk to the child up to 30%. If it's two parents, that can go up 50 to 75%. So imagine that. Just genetics alone plays such a strong role. And you will find often people with bipolar will have people in their family either with bipolar or with depression. So genetics is a big component. Then other things include stress. So oftentimes people who've had traumatic experiences in life, or people under a lot of stress. And it always amazes me how more often than not, stress plays a role in the development of mental health conditions.
Absolutely.
And definitely in bipolar, there's a big component of that as well.
Dr. Emmanuel, apart from the symptoms that you just spoke about, those high highs, or what we classify as mania, as well as the low lows, also known as the depression, is it always possible to state that a person who may be having some highs and some lows, okay, as soon as I see this is bipolar disorder? Or can you have other medical conditions that can give someone the impression looking on, okay, this person may have bipolar disorder?
Absolutely. I'm glad you raised that point, Dr. Grandison, because it is our standard practice in the evaluation of any patient who comes to us to ensure that what symptoms or whatever the person is presenting it with is not as a result of some underlying medical condition, or because of medication, or because of substance use. Right. So we go to pains to physically examine the patient. We do a number of blood investigations. We do a CT brain, because sometimes on the possible cause could be some type of tumor that is creating these difficulties for the person. And so we check kidney function, liver function, blood sugar, thyroid. We do a thorough physical and, as I said, blood investigation, CT brain, and we do a urine toxicology screen. Because as you can imagine, substances like marijuana may present with a kind of manic type episode, or even something like tramadol, or sometimes when people are being treated with steroids, you can present in this way. So we never assume oh, this is a mental health problem, let's go straight and start, treating as if it's mental health, because that would be quite dangerous. So we make a point of ruling out, and that's the point. You have to rule out conditions that may present with mental health symptoms, but actually be because of a physical health underlying problem. And so that's why we go through and ensure that those things are ruled out first before coming to, and even so, I wouldn't even say coming to a conclusion, because I think it's important to have a differential in your mind and be open to changing. If you have a different history or something comes up as you see the person more and more, be very open to changing what you originally thought about was the reason for this problem, and recognizing that, things may look one way, but they become something else as you know more and as you understand more. So we do make a point, because the thing is, once you give somebody a diagnosis, then you are saying, this is what I think, and you do not want to give a diagnosis that is not accurate. Right. So it's important for us to do these checks and to be clear as to what it is we're doing.
Right. Dr. Emmanuel, you spoke just now about one of the significant environmental factors of stress. And we are in a very stressful period with the pandemic here right now. And I know that World Bipolar Day, its theme for this year really is strength for today, hope for tomorrow. Now, some person who may have either noticed a friend or even themselves noticing that, hey, my mood is sort of changing. This is not me. I don't know what's going on, but this is not me. Walk us through what steps they should take, either for themselves or for a friend or loved one, in terms of seeking help.
Right. So I think there's so much, and you raised the point about today being World Bipolar Day, and the idea behind that day is to raise awareness and reduce stigma. Yeah. Because there's so much stigma around, but mental illness in general. But today we're focusing on bipolar, and I bring that up because so often people are so hesitant, and it's really, it's very concerning to me as a psychiatrist that people remain to today in 2021 so hesitant to access care. And when you think about, I think about myself and my colleagues and how much work we put into trying to raise awareness, right, because we want to see a reduction in the stigma. And still, in spite of all that is available, people still pretty much shy away. And we understand that because we do know how some people in the general public react and respond to people seeking help. But we always encourage people to do so, because we do recognize that there is no need to suffer in silence. And absolutely. So often we see people who for years in some instances, right, especially when it comes to depression, people would quietly be at the bottom, so low, can't sleep, losing weight, irritable, just cannot function, and will not say anything because of the fear of how people will treat them. Right. And so we always seek to advocate reaching out. You don't have to come to us first. You can let your general practitioner, if you are very concerned when you're going to see a psychiatrist, then let your general practitioner be your first call, your nurse, maybe a colleague that you trust. The point is reach out to somebody and let them help. Reach out to a family member that you trust, a absolutely. Friend, somebody at church, somebody. But sitting and suffering in silence is not. There is help. I can't emphasize this enough. There is so much help out there. And fortunately, in Barbados, we're in a situation where we have access to trained nurses, trained doctors, whether it's psychiatrists, general practitioners, people who are well aware as to how to assess you and how to point, even if they themselves are not comfortable, where to point you to and to whom to go. Okay, we have the counselors, we have the psychologists, we have the medication if that is deemed necessary. So there is absolutely no reason for you to be suffering and not getting the care that you need.
Absolutely.
Much in the same way. If you have diabetes and it's out of control, or you fell down and you broke a limb or something, you go and see somebody.
Yeah.
Right? You don't sit in pain or your blood sugar is going low and you're sitting there wondering what to do. You go and you see your doctor. We would like to encourage people in the same way, whether it's through the polyclinic system. And right now in the polyclinics, we have a trained psychiatrist and mental health nurses who are present in every polyclinic every week. I don't know if many people know this, but we just like to let people know that they're not there every day, but there is somebody at your polyclinic every week that if you need to see a psychiatrist, you can have access to a psychiatrist. There is access through the Queen Elizabeth Hospital, where we have outpatient clinics and we have an inpatient unit if that is needed. There is access to the psychiatric hospital, where there are clinics going on there Monday to Friday every day. There are child guidance clinics specifically for children.
Right.
There are psychological services, occupational health services. So there are services. People just need to access them. As I said, you can do that via your polyclinic doctor or your general practitioner. Go ahead.
And I'm really glad that you talked about that, Dr. Emmanuel, because I think that part of the concern, apart from the stigma that is really associated with mental health disorders, which really shouldn't be, because as you correctly stated, mental health disorders, just like if you had an endocrine problem or if you had an ortho problem, a broken limb, right, you would seek help because you're in pain, and it's just another organ system that's involved that has a problem with that organ system, and you require the help to actually get back to normalcy. And I think it is a very, very important thing. But I'm happy that you highlighted all of the various avenues that we have available to us here on the island, whether it's in a private setting, in a public setting, polyclinics, again, the Queen Elizabeth Hospital, as well as a psychiatric hospital. So wherever you feel comfortable, you can simply plug in and get that help that you need.
Yeah. And I know we're talking specifically about bipolar disorders, but just to make the point that, I think a big part of the stigma is that people have associated going to see the quote unquote mad doctor, which clearly that we don't like that term because it's just, that's erroneous.
Right.
Most by far, the majority of people who come to see me is for anxiety and for depression.
Right.
Far and away, because those conditions are much more prevalent, much more common than psychosis or somebody who is hallucinating or whatever. So there's this, and I suppose over the years, psychiatry has gotten a bad rap. I think sometimes we did that to ourselves because, from historical times when ECT was being unmodified, ECT in university, shock therapy, and then we hear in the movies and the way people are portrayed mental illness. So that did not help, and I understand that. But we as a community, we work towards changing the perception of psychiatry and the old bygone days of those we just used to be shackled and not really treated very humanely and that kind of thing. We are way past all of that, and it's unfortunate that people still have the mindset, I'm not going to see a psychiatrist. Sometimes people don't even want me to sign their sick leave form because obviously That's all I practice is psychiatry. So if I find you're sick form into something, you get into something mental health, and that's really sad.
Yeah.
That people can feel so afraid that they would not seek treatment for that reason. But just back to my original point, that the common reasons people come to see a psychiatrist, it would be for depression and anxiety, and not for psychotic type disorder. So a lot of misconceptions there, unfortunately.
Absolutely. And if I may go slightly off point here, Dr. Emmanuel, I remember when I was actually in graduate school, my mentor at the time and boss, he would always tell me, the higher up you go on the educational rung, it's important to have some person that you can sit down and have a conversation with and vent
Right.
and let it out. And it doesn't mean that you are unstable. It doesn't mean that you should be stigmatized. It doesn't mean anything. And it is a very healthy practice to get, if there's something that's bothering you or something that you cannot solve on your own, to reach out, to get help, to ask for assistance, because sometimes all it requires is for you to have that conversation, to get a different perspective. And I think that is all part of starting to really normalize getting mental health assistance, and normalize seeking help, which is something that really is stigmatized. I see we have a comment here being made in the chat. I believe that the issue of mental health is stigmatized because of how we are socialized, which is true. The mindset is once mad, always mad. I agree that programs such as this should be used to educate, and I think that's part of our problem. Even how the psychiatric hospital was labeled as the madhouse or Jenkins. Those types of things have sort of really damage how we view the need to seek assistance if we do. But
I think I was just going to make the comment that if we think of preventative measures, seeing a counselor, a psychologist, or psychiatrist as prevention. In other words, things are stressful, you're starting to feel, or even before things get stressful, because one of the things we teach people, how do you cope? What are the things that you build into your life schedule that allows you to decompress at the end of the day, which is better than waiting until things are running over and you're feeling quite overwhelmed to then see a counselor or psychologist or psychiatrist. So if people think of it as just as you would eat healthily and exercise, you can see your counselor, see your psychologist, have a chat with your psychiatrist, and as you said, normalize that interaction.
Right.
As opposed to waiting till things difficult and then speak as a healthcare.
Absolutely. Dr. Emmanuel, tell us a bit about your patient has reached out, whether it is to some person like myself, which is in general practice, or come directly to a specialist like yourself. What does therapy look like, and will a person always have to be hospitalized during an episode?
That's a good question, because sometimes patients are so worried about seeing you. I couldn't sleep last night because I didn't know what to expect. And I just wondered what you were doing. And, again, coming with the misconceptions or the preconceived ideas about what does a psychiatrist do. And sometimes I joke and say, I'm not doing any kind of funny hocus pocus. We're going to sit and we're going to talk. And that's how we're going to start. Sometimes I've had one or two times a patient enter the room and they lie down. There's a changing. I'm like, no, we're not doing that. We're just going to sit down. We're going to sit down and we're going to talk about what's been going on. So the process is pretty much just that. We sit and we talk. But as a psychiatrist, we are trained in asking questions. So we ask questions in a certain way.
Right.
I'm not made it in a very kind of rote manner, because that's part of the beauty of it is being able to ask questions, but being able to modify your approach with each individual patient based on your interaction with that person. So I can ask 5 different people the same thing, but ask them in a different way. And that's how we are trained, right?
Right.
So we ask questions, we ask it in different ways. We try to pull your thoughts, your feelings from you and try to come up what we see at the end with a formulation, which basically looks at all of your factors across your lifetime that are contributing to the way in which we present now. So just to give an example, any 5 people can come in saying that they feel depressed, but in each history, there are different traumatic things, or there may be nothing traumatic. There may be anxiety associated with it. There may be a history of several moves through life for one person that's creating anxiety. The point is, every person, their experience will be different. And although everybody will have the same diagnosis, how we get there will be very different from one person to the next. So there's a lot of talking involved, and the psychiatrists and psychologists, as I said, are trained in eliciting information and in doing it in a manner where the person feels comfortable and confident. Because remember, we get into details that oftentimes, sometimes patients don't even tell their spouse the things that they will come and tell us.
Absolutely.
Right? So, and you have to have the skill to do that, to elicit that kind of information without judgment. Because again, that's the other thing patients complain about. They don't want to talk about certain things because in the past they have raised it or they try to read it. People look at them funny, people laugh, people kind of scrub the face. You know, people get all respond in all different ways. And a big thing about how we approach is not to judge. We are here to hear you,
right,
and understand you and help you walk through these difficulties coming out at the other end. We're not to pass judgment or to give you a plan, because it would be out of order to tell somebody, well, this is what you must do. That will not be the approach. It's very much one of collaboration and of nothing to be afraid of, right? I think people, as I said, a lot of times people just don't know what to expect, and so they're terrified. But there's nothing to be afraid of.
Absolutely. We have a question here from Sam. Can you explain what is a nervous breakdown?
Well, that means different things to different people. So it's not a medical term.
Right.
Sometimes when people use the term, they are describing anxiety. Sometimes when they use the term, they are describing psychotic type symptoms. So it's not a medical term, but people use it for different things.
Right.
Okay? So that will be the role of your assessor, whether it's a psychologist or psychiatrist, to try to determine what is it you are referring to when you say you're having a nervous breakdown. But for the most part, it's usually some type of anxiety disorder, or, as I said, some type of other type of mental health disorder. So I hope that explains, because as I said, it's not a medical term, so people mean all sorts of things by saying nervous breakdown.
Absolutely. How can one really distinguish between what is the bipolar disorder effects and what is the real person? Because as you said when we first started, the person may be the life of the party, joker in the crowd.
Yeah.
How do you know if this is who this person innately is, or if this is a bipolar disorder actually rearing its head?
Right. So that's an excellent question, because oftentimes it can be difficult. But I think what makes the distinction there is the ability to function. So if we use, it's normal, for example, to feel anxious. But if you feel so anxious that you cannot get out of your house, you cannot go into your car, you can't drive, you can't complete your task, then definitely that is indicative of a problem. And similarly, if you are the life of the party, that's fine. But if you are so much into partying every night that you're up until 5 o'clock the next morning and you can't get into work and you're not doing the things that you're supposed to be doing, you can't function, then clearly that's a different thing. So, and I'm glad this question was raised, because I do not want people listening to leave here feeling that we are medicalizing what would be just a happy-go-lucky person. Right. That is not what I am describing. I am not describing the person who, there are people who, when you think of your own, maybe even your own self or even your family and your friends, there's some of us are quite chatty and love to laugh and like to go out. That is not what I'm referring to. I'm talking about a person whose behavior is so over the top that is affecting their ability to function normally in society. So whether it's a workplace or at home or wherever they go, problems are created. So that's not just a happy-go-lucky person. Okay? So, if your thoughts are racing to the extent that you cannot complete something you're saying to the point where you jump to something else and into something else and on and on and on, and nobody can follow what you're saying or what you're talking about, that is a problem. So that's very different to somebody who has lots of good ideas and are important to the workplace because they have such good ideas. But if you think of it on a spectrum, when it's so far right that you can't function properly, then that's the problem. But please do not leave this class thinking that, my daughter likes to laugh a lot, so something must be wrong with that. No, it's not that. I'm talking about when things go over the top.
Right. Dr. Emmanuel, you spoke about the different avenues that one can seek to get help. Psychologist, counselor, psychiatrist if needed. But you also spoke about medication if needed. Mm-hmm. What are the different psychotherapies that a person may seek in order to help them manage bipolar disorder?
Right. So we know through research that the combination of medication with talk therapy, and primarily use cognitive behavioral therapy, so combining those two things gives us the best long-term outcome where bipolar is concerned. Okay? So the talk therapy, remember when I was talking earlier about the causes, we talked about stress, but the talk therapy pretty much looks at how do you manage stressors in your life. Right. Okay? Things like identifying how you are thinking and how your thoughts affect how you feel and how you respond to stressful situation. So it is very important, not just medication, but I think, as I said, combining that with talk therapy is the best way to manage any bipolar condition. We use quite a number of different types of medication. Most of the time we use mood stabilizers. And the interesting thing here is up to about 20 years ago, psychiatrists used to use mood stabilizers and antidepressants. But what research has shown us is that when you give somebody with bipolar an antidepressant, even when they're depressed, you are more likely to push them. Yes, their mood goes up, but then you're likely to push them into a manic state by using the antidepressant. So you start off trying to be helpful, but you end up causing the problem. So we have since changed the way in which we use medication. So we focus primarily on mood stabilizers, which do not cause manic or hypomanic states. And we also have other classes of medications like the newer drugs like olanzapine and Seroquel and so on, which help both if the person is having grandiose ideas. Remember when I'm saying sometimes people get these illusions about doing fabulous things and so on. So we use those types of medications for that reason, and they also help with stabilizing the mood. So you would hear people with bipolar often on drugs like ethylene, chrono, depakote, tegretol. Lithium is the one that's the first one that newer ones like Lamictal. So there are lots of medications that we have, and as I was saying earlier, we are fortunate in Barbados in that we have access to all these different things. A lot of our Caribbean neighbors do not. And so they have to rely on one or two, whereas we have access to the full gamut. So if for whatever reason you can't tolerate it or it's not effective for you, then we can always try something else. Sometimes we get into a situation where people are resistant to treatment, treatment resistant depression, and then we start combining medications. But again, you need to be under the care of a specialist if you're going to have to do that. And more reason, I can't emphasize this enough, more reason for people to reach out and get care, because sometimes it's not just a straightforward situation where the first drug you try will work and then that's that. Sometimes you need to have different trials, and sometimes you need to have combinations of medications. But we try to keep that, of course, to the bare minimum. Because the idea is the lowest dose of medication that will keep you well.
Right.
Right?
Right.
And we emphasize that as much as possible.
And Dr. Emmanuel, how important really is psychoeducation? Because that's what we're doing even now. Providing persons with information about their disorder and, as you said earlier, to mechanisms in terms of how they can help themselves to cope better.
There's nothing more important, quite frankly, because I can see you in my office. I have this fabulous plan, and we sit down and we talk, and this, that, and the next, and this is how we're going to do it. And you walk out my office and say, I ain't doing none of that things because this medication caused me side effects, and I didn't know what that doctor did tell me, and I'm done with that. So all those plans is for nothing.
Right.
And so it's important in the beginning, when you are now learning about this condition, that your doctor takes the time to sit down and go through with you every aspect of what is going on with you, including what are the things for you that gives you a better outcome versus not so good outcome, what things to work on, how we're going to manage your stressors, all of those things. So that the person is part and parcel in the decision-making process where the plan is concerned. And that's why I always make the point, I am not there to tell you what to do. I see my role as me giving you information based on my experience and training. I will work with you because you now have to take that information and apply it to your life. And you are the expert on your life, not me.
Right.
Right?
Absolutely.
So I can tell you about what I've read in my textbooks and what research has said and what I've found with the patients that I've seen. But you are the expert in your life. And you take all that we are discussing and you decide what, based on everything that you have said, would work best. And that's what I see my role is as, not to tell you, well, I know better because I've seen lots of people with your condition and therefore I'm telling you this is what you need. I will be out of order to do something like that. And that's how mental health professionals approach psychoeducation with patients, because it's a collaborative effort. It's not me preaching to you.
Right, absolutely.
And I think that's important. Because
Absolutely.
that interaction colors your interactions going forward.
Absolutely.
If your first experience is horrible with the doctor or whomever, then you forever have this negative mindset about treatment and going to see the doctor and medication, and they're going to put me in hospital and all these other things that come along with it. Which reminds me that, Grandison, you asked the question about whether admission is always necessary.
Yeah.
It is not always necessary. If you have somebody early enough in their illness, and this is why it's important that we train patients how to recognize symptoms early.
Right.
So I'm not talking about somebody who's presenting for the first time. So if you've been through this situation before, come and tell me when you find that you're waking up at 3 o'clock as opposed to sleeping until 6. That is when I want you coming back to me. Right. Not when not sleeping at all and you're disruptive and problems at work. Tell me as soon what we call your early relapse signature. Right. Because as I was saying earlier, everybody will be different. Right. So I want to know, what do you experience when things are not going well? And that takes some time, right? Because obviously when it happens the first time, you're not going to know that. You just feel something is not right and you're not yourself. But beyond that, we do a lot of training around how do you recognize signs and symptoms early so that you do not need to come into hospital.
Right. Right. And I think that's important because the more you empower yourself or the more you are empowered, the earlier you can get assistance and the sooner you return to normalcy. And Dr. Emmanuel, my very last question, and I always ask this here with all topics that I have, is there a normal life with bipolar disorder?
There can absolutely be a normal life that involves managing your symptoms because there is no cure for bipolar, but we can definitely manage your symptoms. And I have patients who function at the highest level, the absolute highest levels, and they function just fine because they have been able to get the right combination of talk therapy and medication therapy that works for them. Right. It is very much possible. And I would like to encourage people, whether it's bipolar, whether it's anxiety, whatever mental health condition you may have, to reach out. Don't be afraid. Don't be to reach out. Reach out to somebody, some professional who can, if not help you themselves, they can put you on the right path to getting the care that you need. The short answer to that question is yes. There is a productive, functioning life for people with bipolar.
And my very last question for this evening is, I've started to feel better. My symptoms have resolved. I'm back to my baseline, or what I would say is normalcy. Can I stop my medication?
That's why I said just now that there are treatments to control, but so far we have not had cure for bipolar. So what tends to happen, if you're given that diagnosis because you've been ruled out any other medical thing and you're realized that this is the diagnosis, if you stop your medication, it increases your chances of relapse. And you see that happen often with people, as you said, completely symptom-free and say, but why are you taking this medication? If I feel good. And then you stop the medication, 4 or 6 weeks later, you find people slowly start either into a manic episode or into a depressed episode. So we do not advocate staying off medication. We would bring the doses down to the lowest dose that keeps you well, but we would recommend that you remain on your medication. And that's why it needs to be a collaborative effort between you and your care provider. You have you and that person need to work close together to ensure that you will well.
Dr. Emmanuel, I want to say thank you very much. Despite our little technical difficulties, we found a way.
My apologies again for that.
It's okay. We persevered and we found a way to ensure that we were able to talk about bipolar disorder this evening. And I also want to thank our listeners who decided to come out this evening and they participated in the message board. And once again, I want to encourage you to follow us on both Podbean and Anchor and join us next week for our First Aid Chats by Dr. G, Closing the Gap. And I want to say, Dr. Emmanuel, I'm sure you would probably want to let our listeners know next month some interesting information.
Absolutely. So on the 11th of April and the week following that, we are relaunching our Barbados Association of Psychiatrists. That is an organization of psychiatrists and psychiatrists in training. And we will be doing quite a media blitz. So we'll be on all different media, Instagram, radio, TV, promoting mental health and mental care and awareness, as we said, and reducing stigma. And we're going to have a public lecture as well as a lecture for our medical colleagues. Our public lecture will be on the Friday, which I believe is the 16th, if I'm not mistaken. And then on the Saturday, we'll have a lecture for our medical colleagues who spend the room. It'll be very soon, so it'll be linked.
And what's happening on the 13th of April, which is a Tuesday?
Right, so we will be back right here with you, Dr. Grandison.
Right.
And we will be talking then about suicide and self-harm and self-care. Dr. Elizabeth Rochester will be joining you to have that very important discussion. And we really look forward to being a part of your listeners again.
Thank you so much, Dr. Emmanuel. Thank you, listeners out there. And once again, continue to be safe during this pandemic. And everybody have a great night. Thank you, Dr. Emmanuel.
Thank you.
Bye-bye.
Thanks for having me. Take care.